Hi, everybody. So today we're going to talk about disorders of the hematopoietic system, which is focused on chapter 20 and 21 are included in this PowerPoint. However, today, just for part one, we're going to only talk about chapter 20. So we're going to start talking about blood. So the thing I want you to notice about this word hematopoietic is that beginning prefix. So heme, anytime you see heme or hema or hemo, we are referring to the blood. So if you hear of someone seeing a hematologist, they have some sort of a blood disorder going on. They need to be seen by a specialist who is focused on study of blood and blood disorders. So I just wanted to talk about that briefly and then jump right into the fact that all of the organs in our body need oxygen and nutrition. They need nutrients. So the way we transport those nutrients and any necessary components is through the blood. So we are utilizing the hematologic system for delivery of any substances that are needed for cellular metabolism. That's one of the things it does, as well as transporting oxygen, which is an essential component of that cellular metabolism. We are also utilizing the hematologic system to remove waste products from the blood, as well as to help us defend against microorganisms and injury. We've just finished talking about inflammation and what happens when we have an injury, what that response is in our body. And then another important component of the hematologic system, or that blood system, is the maintenance of acid-base balance in the body. So our body, remember, likes homeostasis. We've talked about that before. And one of the ways that we help to achieve that is through the hematologic system in maintaining our acids versus our bases so that we're at a happy medium, or a hemostasis condition. So when we talk about the components of blood, or what composes blood, your book talks about it being approximately 91 to 92% water. It says one thing in the beginning and one thing in the end, but we'll just say around 92% water, and 8 to 9% solutes. And solutes, remember, are just dissolved substances. So that can be the many nutrients that are in the body that we're transferring from place to place. It can be immunoglobulins. It can be any number of substances. Keeping in mind that we have about 6 quarts or 5.5 liters of blood in the average size body. So this is a 1 liter bottle. So we've got at least 5.5 of these roaming around, give or take, based on things like how hydrated you are. If you've had a recent episode of bleeding, those kind of things can change that composition just a little bit. But basically, when we talk about blood, we want to talk about components of that. So essentially, we need red blood cells in order to transport oxygen. And then we need a fluid portion of the blood for nutrient transport, basically. And then when we talk about plasma, we're talking about the various cells that are circulating are suspended in a solution of proteins and inorganic materials, and that's what plasma is. So plasma makes up about half of the blood volume in our bodies, and it's really essential because it is the primary component of plasma are proteins, and proteins are really important, particularly in maintaining fluid balance in our body. So there are 2 primary proteins in our body, and that's albumins and globulins. And then we also have a component of clotting factors that are part of the plasma, which we'll talk about too. So the concentration, again, of plasma varies based on things like dietary intake, metabolic demands. So how hard are you working at that time? Are you an athlete that's demanding a whole lot of your body throughout the day, or do you lead a more sedentary lifestyle? Things like hormones and vitamin levels also are a component of the concentration of plasma. And then we've got these specific proteins. So albumin is really the carrier for normal components of blood, and for drugs as well. And the primary function of albumin in the body is to control something called plasma oncotic pressure. So what that really means is it regulates the passage of water and solutes through the capillary beds in the body. So if we think of vessels, and those are a little bit larger tubes that are traveling to all of the faraway places in our body, like our hands and our feet. Within those areas of the body, the vessels are going to transport blood and nutrients to the capillary beds, which are the teeny tiny little vessels that make sure that the ends of your fingertips are getting enough blood supply, the ends of your toes, things like that. So we have capillary beds everywhere. And the albumin is really responsible for the fluid balance in those areas. So this is really important because when we see someone that has something like edema, so that's that swelling that we get, sometimes you'll see lots of ankle swelling in patients with heart conditions. And that's because there have been changes in the oncotic pressure, and we'll talk about that when we get to cardiac. But albumin is this very large molecule that doesn't pass easily across a membrane because it's so big. And so that helps it to maintain our oncotic pressure, meaning it keeps all the fluid in the right compartments. It keeps the fluid where it's supposed to be. Globulins are another carrier protein, and they help basically in the movement of things like immunoglobulins, which are antibodies, which we just talked about extensively. And then the other component of plasma proteins are our clotting factors. And the main one I want you to focus on for our purposes is fibrinogen. And remembering that fibrinogen and then fibrin are what's responsible for us being able to make a clot. And we're going to go into more detail about that. All right, so let's talk about the composition of blood. So what's in it? What cellular components are in blood? So we've got erythrocytes, which we talked about kind of in the first weeks of class. And erythrocytes, remember, are our red blood cells. We have, in men, red blood cells make up about 48% of the blood, give or take. And in women, it's about 42%. So it's the most abundant cell in the body. And it is responsible for us being able to oxygenate our tissues. So remember, the hemoglobin molecule attaches to the erythrocyte, and that allows us to transport oxygen where it needs to go and then collect carbon dioxide or waste products and take it out of the body. Biconcavity and reversible deformity refers to the shape of a red blood cell, which is very unique and allows it to travel through really small vasculature. We call it microvasculature. That's places like, again, in the tips of your fingers, the tips of your toes, your eyes, some very tiny places through the kidneys, lungs, liver, all those places. So the shape of a red blood cell is sort of like a donut, but the hole doesn't go all the way through. It's just compressed. And that allows for it to morph and change shape as it squeezes through these tight places in order for it to be able to deliver oxygen to all of the tissues it needs to get to. And then it has a really, really long life cycle. So red blood cells last about 120 days, which is very long as compared to platelets, which we'll talk about as we move down the line. All right, and then we've got leukocytes. So these are the white blood cells. And we've already talked about how these cells are a huge component of our body's defenses against infection, as well as leukocytes have a place in removing debris when we do break down either antigens or our own cells that have lived out their life cycle. And these are made up of two categories, granulocytes and agranulocytes. Right now we're going to talk about granulocytes. So these are basically they're membrane bound granules in the cytoplasm. And remember, we're talking about neutrophils, basophils, eosinophils. Those are our primaries that we're going to talk about here. These granules have these little enzymes in them that we are thankful are able to destroy microorganisms, whether that's a bacteria, a virus, fungi, parasites, all those things we just finished talking about, and plays a role in mediating or controlling the inflammatory process and our immune functions. And then a special skill that they have is they can move like an amoeba. So this means they can basically migrate through vessel walls in order to get to the necessary sites. Because many times when you get an infection, hopefully, it's not in your bloodstream. It's actually, let's say you cut yourself on your arm and it didn't get cleaned real well and it got infected. So your granulocytes are able to actually move through vessel walls and get themselves to where they need to be in order to provide protection, inflammation, immune response, whatever that happens to be. Okay, and then agranulocytes, remember, are monocytes and macrophages that do the phagocytosis of those kind of waste products, or if we're killing bacteria or anything like that. And then also lymphocytes fall into the agranulocyte category, which are the cells that create immunity, like we've been talking about. Okay, so moving on, we've talked about erythrocytes, which are the red blood cells. We've talked about leukocytes, which are the white blood cells. And now we're going to talk about platelets briefly. We'll go into a little more depth in a moment, but platelets are not true cells. They're irregularly shaped cytoplasmic fragments of a gigantic cell called a megakaryocyte. The real thing I want you to focus on for this chapter is that platelets are absolutely essential for coagulation and controlling bleeding. So that's where we want to focus when we're talking about platelets for the purposes of this chapter. Okay, and we'll go into more depth in a minute. All right, moving on to another component of the hematologic system is we have to talk about lymphoid organs. So the lymphoid system is really closely associated with the circulatory system because they're all kind of interconnected. So the spleen is the largest secondary lymph organ that we have in the body. It's the site of fetal hematopoiesis. So that's the fetus producing their own blood cells. And essentially, the younger a person is, the more blood cells they will have, and then they will sort of stabilize over time to a more normal range. So the spleen is responsible for that early initiation of the production of blood cells. The spleen is also responsible for filtering and cleaning the blood. It initiates immune responses, so it is really important in our immune system. And again, remember, it's part of the lymphoid system, but it really is essential in that immune function like we've been talking about. And then the spleen is also a reservoir. So it can store up to about 300 mLs of blood, which can be really useful should our blood volume drop in the system. We could pull from this storage area here. So if you look at the splenic pulp, just the purpose of that, or what it is it's masses of lymphoid tissue that contains these components. So macrophages, lymphocytes, and then lymphoid follicles. They basically collect interstitial fluid from our tissues. So interstitial fluid is the fluid within the tissues, and then it transports it as lymph back to circulation. And that's part of the venous sinus process, which is when the lymph system detects a problem, an invader, whatever it happens to be, it will identify it. It will send appropriate cells to deal with it, but then it'll clean things up. And so a lot of that happens in the spleen. So we can phagocytose or eat up those old damaged, dead blood cells, but also we can help to clean out and get rid of any byproducts of cell breakdown related to an injury or to an infection. And then another large component that we want to talk about in the lymphoid organs are the lymph nodes. So lots of us familiar with lymph nodes. When you get a cold, when you get an infection, you will notice that your lymph nodes get enlarged. Sometimes here in the neck, cervical spine area, kind of behind the back of the head, neck rather, and then pre-auricular and post-auricular are in front of the ear and then behind the ear. So those will become swollen and enlarged when the lymph system is on high alert or taking care of a problem. But what else they do is they help facilitate maturation of lymphocytes. That just means they help the lymphocytes grow up into whatever cells of the lymph system they're going to be. They also help transport lymph fluid back to circulation, because we've got to bring some of those components back to circulation in order to be able to clean out the system, basically. And then also the lymph nodes help to cleanse the lymphatic fluid and get rid of any microorganisms or foreign debris that happens to be there. Okay, hematopoiesis is defined as the process of blood cell production. And this is something that's constantly ongoing in the body. We need about 100 billion new blood cells every day, and that's blood cells of every kind. So this mechanism, hematopoiesis, is that process of making those 100 billion blood cells every day. So it's a huge operation. You're going to hear a term in your book or read a term called extramedullary hematopoiesis. So I put the definition just underneath for you. So that is defined as blood cell production in tissues other than bone marrow. So in normal hematopoiesis, this blood cell production should take place in the bone marrow. But sometimes what happens is we can get blood cell production in other tissues, like the spleen and the liver are kind of the primary sites, but lymph nodes, adrenal glands, there's all kinds of different places that this can happen. But when it does happen, it usually is a sign of a disease process. And those examples would be things like pernicious anemia, sickle cell anemia, some leukemias. There's a condition called thalassemia. These are all disease processes that need to be dealt with when we're seeing extramedullary hematopoiesis, which is creation of blood cells in tissues other than the bone marrow. That's all I want you to know about this. There's a big section in your book, but don't focus on it. Okay, the other site, well, the main site where we should be having hematopoiesis occur is the bone marrow. So this is the factory, as it were. It's the primary residence, basically, of what you'll hear called hematopoietic stem cells. So this is where our stem cells are going to turn into whatever they're supposed to be. We have red marrow and we have yellow marrow. So our red marrow is our active marrow. This is the section of the bone marrow that's actively producing cells, and that's why it's red. And then we have yellow bone marrow, which is inactive bone marrow. It's an area where we store large quantities of fat within the bone itself. And it's usually found in the cavities of all of the bones you don't see listed here. So our red marrow, our active bone marrow, gets produced primarily in the pelvic bones and the vertebrae. Those are the biggest sites. And then there's smaller amounts of production in the cranium and the mandible. So in the skull and in your jawbone. The sternum here in the front and some of the ribs. Let's see, the proximal portions of the humerus. So humerus is your upper arm bone. So proximal means upper, distal means lower. So proximal section of the humerus and the femur, which is the big leg bone, the top of your thigh. And then within the bone marrow, we have these little areas called niches. These are just basically little compartments where differentiation of blood cells happens. So that means differentiation means the cells are turning into either a red blood cell or a white blood cell or a platelet or whatever that may be. Don't get bogged down by these names, but mesenchymal stem cells are going to turn into things like that's wrong. It's osteoblasts with a B. Fibroblasts, adipocytes, chondrocytes. So these are the mesenchymal stem cells are going to make cells of things like the cartilage and the bone and things like that. Hematopoietic stem cells are, because remember, you see the heme in there, are going to turn into blood cells. And what they need to be able to do that is something called a colony stimulating factor. So a colony stimulating factor is a cytokine, and it basically is produced by endothelial cells, fibroblasts and lymphocytes, but it stimulates the body to make more blood cells. So in order to have a normal production of blood cells, you need an effective amount of colony stimulating factors. We're going to talk about that a little bit more. The neat thing is now we've developed a synthetic version of colony stimulating factors. So if a person has a problem making those CSFs themselves, we can give them, excuse me, a synthetic version to help their bone marrow continue to make cells, which is really nice in things like cancer. When we give chemotherapy that kills rapidly dividing cells like our blood cells, and we need to help bump that person up, we can give them a synthetic version of a colony stimulating factor to help them recover more quickly, which is kind of cool. Okay, so erythropoiesis. So this is the development of erythrocytes. So that's our red blood cells. So essentially what happens in the body is it's going to respond when we have a drop in oxygen levels in the body. It's going to respond by saying, hey, there's not enough oxygen, so there must not be enough hemoglobin to transport it, so I need to make more red blood cells. So when that happens, and it happens for a couple of reasons, or lots of reasons actually, things like anemia, things like living at high altitude or going to a high altitude. So if you take a hike to the top of Mount Whitney, there's less available oxygen in the air. And so one of the ways the body compensates for us having a lower O2 level within the body, or lower available oxygen, is make more red blood cells, because then you'll be able to bind oxygen to more, you'll have more available hemoglobin in order to transport oxygen around. Pulmonary diseases, so diseases of the lungs, can affect this, as well as kidney failure, because the kidneys are where we make something called erythropoietin, which is that colony stimulating factor that tells our body to make specifically red blood cells. So what happens when we have erythropoiesis is that we start with the bone marrow, and the bone marrow makes something called an erythroblast, which is going to mature and grow up into an erythrocyte. In order to begin maturing, the bone marrow needs to be stimulated by erythropoietin, which is that substance that's secreted from the kidneys to tell our body, hey, make more red blood cells. So when erythropoietin gets released, it causes an increase in red blood cell production, which then gets released from the bone marrow into circulation. I put the sequence here. I'm not going to test you on the sequence of what happens, but if that interests you, there you go. So two things happen when we have a decreased amount of oxygen in the body. One, we increase our respiratory rate, because then we can bring in more oxygen. So we start breathing faster. Then the second thing that happens or gets triggered is that erythropoietin gets released from the kidneys to stimulate production of more red blood cells within the body. Okay, so that being said, we can't just have an ongoing, never-ending production of red blood cells. We need to kind of maintain that homeostasis, or that happy place. So we do have a relatively constant number of red cells within the body. We already talked about how the kidney produces that erythropoietin, and that it's in response to a hypoxic situation that, number one, we increase our respiratory rate, and then number two, it signals the kidneys to release erythropoietin. Okay, so let's talk about hemoglobin synthesis. So we know that hemoglobin is the oxygen carrying component of an erythrocyte. So there's two pairs of polypeptide chains, which are referred to as globins, as in hemoglobin, right? And then four colorful iron protoporphyrin complexes, that's a hard word to say, which are the heme. So we can attach four oxygen molecules to every erythrocyte, basically, as we're carrying things around the body. So we get the name hemoglobin from heme, which is those iron components, and then globins, which are the pairs of polypeptide chains. And then incidentally, just a fun fact, you get that bright red color in blood from the heme, and that's because of the iron component there. Okay, so in the body, we have an iron cycle that happens. On page 503 in your textbook, it's figure 20-15, has a really great picture of that. In fact, I think I didn't put that one in here, but essentially, we have something in our body called total body iron. And total body iron is hooked up or bound to, like a key in a lock, to heme, and that's when it's being transported, or it's stored and bound to something called ferritin. So essentially, we've got about 67% of the iron, the total body iron in your body, is bound up to heme. And then 30% of it gets stored, bound to ferritin. It gets stored in these mononuclear phagocytes. I'm not going to test you on the names of all this stuff. I just want you to understand that some of the iron in our body is circulating and some of it is in storage. So we've got a backup, basically. We need about 25 milligrams a day of iron in order to produce red blood cells and have active hemoglobin synthesis. But we only get about 1 to 2 milligrams in our diet daily. And this is people who eat well. And as we all know, not lots of people eat well. So we get iron from, of course, red meat. We also get a good amount of iron from our leafy greens. We need good components of B12 and B6, folic acid in our diet, things like that are all really important components to this iron cycle. But we only get about 1 to 2 milligrams of iron in our diet. So where do the other 23 milligrams come from? And that's where we come into the storage component. So I put these fancy names here. Again, don't get married to the names. I just want you to understand that iron is transported bound to something called apotransferrin. And then once it binds up, it converts into something called transferrin. And that allows, so that the trans part of that always makes me think of transport, and transferrin is what allows iron to be transported to the bone marrow to be utilized to make red blood cells. So what happens is iron gets released by the epithelial cells in your GI tract. So you either absorb it or you rely on stores that we have as a backup. It gets carried by the transferrin, remember the transporter, transferrin, into the bone marrow. It gets incorporated in the process, of hemoglobin, making hemoglobin. And then as the cells mature into erythrocytes, they circulate for about 120 days and they do their job. And then they essentially recycle themselves and return some iron to the bloodstream and essentially kind of do it all over again. So we keep utilizing our iron stores on a regular basis in order to be able to continue this process of erythropoiesis and hemoglobin synthesis. So we have a normal amount of cells every day that have reached their maximum lifespan of about 120 days. And they get what's called sequestered, which means they get collected together, usually in the spleen, and then they get destroyed by macrophages. And essentially the components that can be recycled get recycled and the waste products get removed from our system. If for some reason someone doesn't have a spleen, so let's say they had an accident and their spleen ruptured and had to be removed, the liver can take over this part of the job, essentially. So it's not quite as good as the spleen is at the job, but it can go ahead and take over there. And then porphyrin is, don't worry about this section in terms of like memorizing it, but essentially this component of the red blood cell, porphyrin, gets basically turned into bilirubin, which then gets transported to the liver and gets secreted in something called the bile. And the bile is what gives us, gives our stool the brown color. So it's the byproduct of red cell breakdown is what essentially is bilirubin, that then gets transported to the liver and secreted in the bile, gives our poop that brown color. Okay, so let's talk about leukocytes. Remember, leukocytes are white blood cells. And these are lymphocytes, granulocytes, and monocytes, okay? So leukocytes come from the stem cells in the bone marrow. Granulocytes, so leukocytes are the broad category, and then three little lines coming down underneath that: lymphocytes, granulocytes, and monocytes. So granulocytes actually mature in the bone marrow. So they grow up in the bone marrow and then get released. The agranulocytes and the monocytes get released into the bloodstream as immature, kind of child-aged cells, for lack of a better description. And then they grow up as they're needed, essentially. And that's kind of what we talked about in the components of the immune system and how those cells get activated. We have things called growth factors and colony stimulating factors that help us to produce these kinds of cells, whichever kind it is that we need. So if the body experiences a decrease in red blood cells, whether it's numbers or lack of oxygen to the tissues, it's going to release erythropoietin, which is that colony stimulating factor. It's going to tell us to make more red blood cells. We can see an increased production of leukocytes, remember the white blood cell category, whenever we have infection, if someone is using steroids, and if for some reason they have a reduction in their bone marrow reserves. And that can happen for a lot of different reasons. One of the reasons is we give you a medication that suppresses the bone marrow. There are some genetic disorders that can contribute to this. So anytime there is presence of infection, presence of steroids, or reduced bone marrow reserves, we're going to see increased production of these white blood cells. All right, and then when we're talking about platelets, we undergo something called endomitosis. So this is the part where platelets aren't really and truly a cell, in that they come from a megakaryocyte, which is a type of cell. Megakaryocytes, they do DNA replication, but they never undergo cytokinesis. So that's that splitting off of a daughter cell. So I make a copy of my DNA, I replicate all the cellular components, that cell breaks off and becomes its own thing. That's what normally happens. But in megakaryocytes, the DNA replicates, but it never breaks off into its own cell. So that megakaryote just gets more mega and more mega and more mega. And what ultimately happens is it just breaks apart into fragments. And that's what the platelets are. So platelet levels are regulated by something called thrombopoietin. And if you think of thrombo or thrombosis, that's a clot. And so when we think of platelets, the colony stimulating factor is thrombopoietin. Platelets only circulate for 10 days, and then they don't really work effectively anymore. So whereas red blood cells last about 120 days, platelets really and truly 10 days max. So we're just constantly making more platelets. And then senescent platelets, or that just means old platelets that have lived their lifespan. get sequestered again in the spleen. That just means they get collected and pulled together and then destroyed. And we move on and make more. So constant turning over of cells. Okay, hemostasis. So this vocabulary word is important. It means arrest of bleeding, which means stopping bleeding. So the whole purpose of hemostasis means that bleeding stops. And in order to accomplish this, we need three things. There needs to be three components. Number one, we need platelets. Number two, we need clotting factors. And number three, we need appropriate vasculature. So we need vessels that work. So platelets, remember, are going to help regulate the blood flow in a damaged area. They're going to form a platelet plug. So they will essentially get very sticky. They'll start to stick to the endothelial lining of the vessel wherever the injury is, and then they'll start to stick to each other, and they'll make a perfect little plug. They will also, platelets, will help to activate the clotting cascade. And then they are going to help to initiate the repair process, including things like clot retraction and clot dissolution, which is the dissolving of a clot. And the fancy word for that is fibrinolysis. Clotting factors, we've talked about those in the clotting cascade, but we'll go in a little more detail in a second. And then vasculature is the ability of the vessels to contract. So when you have an injury that results in bleeding, one of the first things that should happen is that your vessels actually contract to reduce the amount of blood that can get through them. Because if you're bleeding, we want to try to stop that. So by contracting, then the vessels get smaller and it helps to slow down the process of bleeding. So I've included this picture, which is in your book, that shows you essentially blood vessel damage. So you can see in number one, you get an injury to that area, and you're going to start seeing platelets to fill in the gap wherever that injury happened to be. Then you're going to start to get adhesion of those platelets. So that's when they get super sticky. And then they're going to start to form a clot, essentially. So first you have blood vessel damage that occurs. Then you get a blood clot formation that starts to happen. And then essentially, once things are healed, what this picture shows is that you then need to dissolve that clot. It can't stay there forever. Once the repairs have been made and the issue is resolved, then that clot needs to dissolve safely and go away, because clots randomly running around the body are very dangerous. And we'll talk about that in some of the disease processes that we get to. So this is just a good picture of what happens. So here is just in words, kind of the same thing. So when platelets get activated, they're going to start sticking to the vascular wall where the injury happens. So adhesion means stickiness. Then the platelets are going to start to degranulate or kind of break apart even further and stick to the walls and stick to themselves. So it's sort of like Spider-Man. He shoots his web out, right? And it sticks to the wall. And then he can actually grab the bad guy, stick him to the spider web, and they're all kind of just stuck in there, right? They can't get out. So that's kind of the principle of what's happening when you're forming a clot there. Again, platelets are going to also help activate the clotting system and create that meshwork of platelets and ultimately fibrin that's going to make that blood clot there. Okay, so we've got, when we're talking about hemostasis or stopping bleeding, we've got a couple of different components of our clotting factors that we want to talk about. So we've got intrinsic pathway and extrinsic pathway. And basically the end goal of this is we want to make a blood clot. We want to make a meshwork of protein strands that are going to stabilize the platelet plug and make it more permanent. Because remember, a platelet plug is really just kind of a temporary emergency measure. We need something that's going to stabilize it and hold it there. And so that's what's going into effect when we activate the clotting factors. So we make these protein strands, which are, they're made of fibrin, which is produced by the clotting system in order to create this more permanent meshwork to protect the area or heal the area there. So the intrinsic pathway, I just want you to know that that is activated with factor 12, because there are disease processes where people do not have enough of a certain kind of factor. And we can give them that factor if we need to now, to be able to help them to stop bleeding. So there's different kinds of what's called hemophilia, which is an inability to clot. And they're different because they lack different clotting factors. So as a nurse, many times I have given different factors to patients in order to make sure that they can stop bleeding. So in the intrinsic pathway, it's factor 12. And in the extrinsic pathway, it's not a specific number, but it's called tissue factor, is released by these damaged endothelial cells. And what happens when these two pathways, both intrinsic and extrinsic, get activated is it leads to the common pathway, which is factor 10. And without factor 10, you can't make a clot. So you've got to be able to activate intrinsic factor, intrinsic pathway, extrinsic pathway. That makes the common pathway happen. You activate factor 10, your body makes a clot. So that's all I want you to know about this. In the book, it's down and dirty and lots of detail, but just recognize you've got to have intrinsic, extrinsic. They both work together to make the common pathway happen. You activate factor 10 in the body, you can make a clot. That's it. Don't go any further in depth than that. So here's the coagulation cascade in a picture form. So you get this injury, you can see over in A, and basically 3 steps happen. So you get a release of clotting factors from the injured tissues, and you get super sticky platelets at the site of that injury. So in this case, it's someone's foot. They stepped on a nail. And the platelets are going to form a temporary plug. That's the first thing that happens. So first, you release clotting factors. You get sticky platelets and a platelet plug at the site. That's number 1. Number 2, you're going to get a series of chemical reactions that happen that result in forming thrombin. And thrombin is going to start the process of making that clot. And then number 3, you're going to get those fibrin protein strands, and that's going to help to augment or grow that platelet plug that's already there and make it more solid, and essentially that's your clot. Okay, so there's just 3 things that are happening when you're looking at this picture. You have an injury, which helps you to release clotting factors, bring platelets to the area, form that platelet plug. Then you're going to get a series of these chemical reactions, and I don't need you to know all the details of those chemical reactions, but ultimately that's going to help you form thrombin. Thrombin's going to work together to help form fibrin, and fibrin's going to make the clot happen. That's it. Okay. All right, then, like I said, once the clotting happens, that's all well and good, but eventually we need to dissolve that clot. I'm sorry, I'm jumping ahead a little bit. First, the clot itself needs to pull back or retract a little bit, which is going to help to bring the edges of the wound together. So what happens is those fibrin strands that we had start to get shorter. They start to get denser and more compacted together. That's going to pull the edges of the injured area, vessel, whatever, together. And all of that's happening because we have tons of platelets that are coming to the site. And then, here we go we need to lyse that blood clot. So we need to break down. So lysis means breakdown, because it can't stay there forever. And clots floating around our body are not a good thing. So basically what's going to happen is the plasminogen is going to bind to the fibrin, and it's going to convert into plasmin. So it starts as plasminogen, it binds with fibrin, turns into plasmin. I don't need you to know all the mechanisms of how that works. But plasmin is essentially an enzyme that dissolves clots. And so that breakdown that process is going to result in something called fibrin degradation products. So once the plasmin is released, that's that enzyme that starts to break down fibrin, we're going to get byproducts, right? There's no action without a reaction. And the byproduct that we're going to talk about is fibrin degradation products, specifically D-dimers. And the reason we care about that is because as nurses, we use a D-dimer blood test to tell us whether or not a patient has something called a DVT, which is a deep vein thrombosis, or a PE, which is a pulmonary embolism. Those are fancy words for a DVT is a clot somewhere in a deep vein. It usually happens in the legs or in the upper arms, usually. It can happen anywhere, but and then a PE is a pulmonary embolism, so that is a clot in the vasculature in the lungs. And we look at D-dimers on a lab value. It's a blood test that we can do to diagnose patients with either a DVT or a PE. Wow, sorry, helicopter flying over my house. So that's the process of breaking down those clots. That D-dimer is the byproduct of breaking down a clot. It's one of the byproducts. It's the only one I want you to focus on for the purposes of this class. And know that we can check for a DVT or a PE, so a deep vein thrombosis or a pulmonary embolism, by running a lab test called a D-dimer. Okay, and then lastly for today, we're going to talk about aging in the hematologic system. So as a newborn, babies typically have a little bit higher number of cells than an adult does, because the system is just getting kickstarted. There's a bit of an overproduction of things that's going to level out as the child gets older to a more normal or regular level as they get older. But as people age, red blood cell lifespan it remains normal, but the process of making them takes a little bit longer, and particularly after bleeding. But those erythrocytes are living about 120 days still, even as you get into the oldest of old years. But it does take a little longer to replace those red blood cells. The reasons for this can be associated with iron depletion. So we're using up our iron stores over time. Plus, honestly, more difficulty getting dietary iron into the body. There can be some changes in iron binding capacity and absorption, because the lining of the gut mucosa just becomes less effective as we get older. It's harder to absorb iron through the GI tract. Lymphocyte function decreases with age, and we already talked about that with our immune stuff. Remember the thymus and how it shrinks. So then we have less, sorry, I'm jumping ahead. The bone marrow, actually, we have a decreased production of lymphocytes. Remember, lymphocytes are in that lymph system in our body as we get older. And then for humoral immunity, less responsive, related to the thymus shrinking, things like that. With platelets, I didn't put it on here because there's no change in platelet numbers or structure, but there's some indication that they might be a little bit stickier as we get older. There's not really a lot of literature on why that is, but essentially the composition of our blood doesn't change very much as we get older, which is a good thing. But a few little things change here and there, like the speed at which we can make red blood cells, the functionality of our lymphocytes, and then the immune system being slightly less responsive as we get older. So we're going to stop here today, and we'll start in on part 2 with anemia and finish up this PowerPoint for part 2. Okay. Thank you all so much. I hope you have a great day, and let me know if you've got any questions at all. Thanks, guys.